My name is Shami Parr. I'm an advocate here at the Disability Rights Center. The Disability Rights Center is a nonprofit agency. We are territory-wide. We work with every kind of disability, certainly including TBI. We work with medical, non-obvious, obvious. We work with people with physical disabilities, mental health, basically any kind of disability that's permanent. We do provide information related to your rights as a person with a disability. We work with people who might need just simple things as information and referral. Sometimes we work with folks who need more support, such as short-term and long-term assistance. That's something we are able to provide to individual disabilities, regardless of age. We work with young people in special education, all the way up to people who are older or seniors who are experiencing disability. So without further ado, I want to make sure to go right ahead and introduce our guest speaker. We are so fortunate. I'm fortunate to work with Dr. Payne through another project with DRCVI. So we are very fortunate not only to have Dr. Payne available to us, she's a very busy woman, but also very much connected to the people and the residents of the Virgin Islands, which is incredibly important for us. So Dr. Mitzi Payne is a professor and a pediatric neurologist at the Marshall University School of Medicine, and a pediatric neurologist here as a practitioner in the Virgin Islands. I'm going to have her introduce herself, give a little background about herself, her education, but also how she got connected to the Virgin Islands. And then she's going to give us a lot of information about TBI as a whole. So Dr. Payne, take it away, and thank you so much for joining us today.
Okay. Thank you so much for having me and giving me this opportunity to speak to you all. I'm Mitzi Payne. I'm a pediatric neurologist in West Virginia. I did my training at LSU in New Orleans. So I have lived through many hurricanes, including Katrina. So I definitely understand the life of the trauma and all associated with that as well. But I got connected to the USVI back in 2018. I had a friend up here in Huntington, West Virginia, who then left Huntington to move to Atlanta to work for the CDC. So when they were putting together a brigade for Zika to a group of, providers to go down and evaluate the kids that had been Zika exposed, they needed a pediatric neurologist. And she mentioned that she threw my name out. And so they asked me if I'd be willing to go. And I said yes. So I went down in the spring of 2018 and just fell in love with it. And at that point, the Department of Health said that they needed a pediatric neurologist, that they had one previously, but didn't have one currently. And so I pretty much just signed up for it, and I've been coming down ever since. And I've really enjoyed my opportunities there. I actually just got back from St. Thomas yesterday, early this morning. So already missing it and missing everyone down there. But I will talk to you today about concussion. My disclaimer is that, of course, I'm a pediatric neurologist, so it's the approach of a pediatric neurologist. A lot of it does, of course, pertain to adults, but it will be from that pediatric perspective. Here in the States, as you probably know, the challenges with head injuries and sports-related injuries are very forefront. So, and mostly liability associated with that. So a lot of my, what I'll be talking about is experience that way. I had starting in 2013 until last year, a pediatrician and I did a multidisciplinary concussion clinic at Marshall. And we, once a week, we saw children that had presumed concussion, diagnosed with concussion, and help them kind of get back into their normal lives. And so a lot of the lectures is kind of, my experiences with that clinic. We're not doing it anymore, and it's a good thing that we're not, and I'll tell you why. Our sports medicine department up here in Huntington has really gone out and done a lot of outreach and is present in the schools, like as athletic trainers and whatnot. And so we're really not needed anymore, which is great. The athletic trainers are trained in concussion and evaluation and management, and they can do a lot of the evaluations at school. which is great because then, the kids don't have to miss as much school. We don't all better doctor visits or fewer doctor visits is probably better for everybody. So it's been a really good thing. So as the athletic trainers have been more involved in the school systems, then our role as physicians has kind of dwindled, which is a good thing. We're very pleased to say that that's happened. So that's been definitely a move in positive direction in our area. That's not present in all areas, however. And West Virginia, where I live, I find a lot of similarities to the Virgin Islands. We are remote, just like you all are remote. You all are separated by water. We're separated by mountains. A lot of times cell signal is poor, just like you all. Transportation is an issue. So a lot of the same barriers that we have here, you all have there. For extra care, that specialty care, a lot of our patients have to leave the state, and it might be a drive of, say, 3 to 5 hours to a bigger center, similar to you all. Instead of driving, you're flying. So we have a lot of parallels with this. So we've kind of learned to manage a lot of our situations kind of close in home in the communities. And as you know, community support is so important, and that's better sustainability, right? That's what we say. You don't want to start up a program and then have it end, and everyone's kind of dependent on this, and then it's not there anymore. So the fact that up here at Marshall, they've had the athletic trainers go into the school systems has been great. Definitely going to be, in the future and continue with that plan. So without much more ado, let me go ahead and start my presentation. All right. Okay. So here I'm going to talk to you today about concussion with mild traumatic brain injury. So what is a concussion? The International Conference on Concussion in Sports has defined it as, quote unquote, a pathophysiologic process affecting the brain induced by a traumatic biomechanical force. So what does this mean? This means that, here's a diagram, football players always get the known head injuries. So here's a depiction of a football player. And this player is wearing a helmet, but we know helmets don't prevent concussions. So the example here is number 1. So there's a force against the front of the helmet. So that may be another head or, another player. It might be a ball. It might be falling to the ground and then hitting the ground with the front of the helmet, in any kind of situation like that. And then what happens is there's kind of this wave that passes through the brain. That's the number 2. And so have you all made Jell-O? And it's like in the bowl, like the Jell-O in the bowl, right? And you can walk it, jiggle it a little bit and it will be okay. But if you jiggle it or shake it too much, you're going to see noticeable tears, right? So imagine the brain is Jell-O and our brain is that pan, that Jell-O mold, whatever it may be that you're making the Jell-O in. Another kind of added problem is that the base of our skull is very bumpy. It has lots of notches, lots of sharp, teeny tiny bones. And so as the brain is moving through the skull, sometimes it can rub on the bottom part of the skull and have some more damage than otherwise it would have. But with Jell-O, you could shake a little bit and not see any tears. But if you were to get out a microscope or some magnifying lens to look at the Jell-O, you might see that there are some really small little tears, just too small that you can't see just by looking at it. So that's a very similar situation with the brain. So going back to our example, we've got in this example, the force is to the front of the skull, and the brain moves back and forth through the skull. And then number 3 is showing that there is an impact to the brain causing some small tearing of blood vessels or nerve damage. And those are those really, really small tears like we might see or not see in the Jell-O. And in humans, if we were to get out a microscope, we could see it, but we can't always see it grossly. All right, so there's 5 major features of a concussion. It's an impact to the head or a direct impact to other parts of the body with the force transmitted to the head. For example, impact to the head, we get that, right? Ball hits your head. But what else could it be? Could it be? Could it be you fall down, say you land on your side, and then your head might hit the ground? Or let's say your head doesn't even hit the ground, but you have a really severe fall and your head is jostled and shaken in a way, kind of like a whiplash injury. You can still have a transmission of force to the head, causing a brain injury where that brain is moving around in the skull. Typically, there's a rapid onset of neurologic impairment. So suddenly there's a headache, or there's confusion, or there's nausea, there's instability. There's going to be some kind of sudden impairment that happens at the time of the injury. If we were to get out our microscope, we would be able to see some structural injuries with the neurons, the blood vessels, the synapses that are occurring. But as you know, this isn't going to happen in a typical manner, but this is one of the major changes that we see in a concussion. There's a graded set of symptoms that may or may not involve loss of consciousness. So you don't have to have loss of consciousness to have a concussion. So you could have maybe a confusion, off balance, nausea, memory loss, some slurred speech, that then might improve slowly. Or you could have a sudden neurologic deficit that then worsens. So either way, it may get worse or better, but your symptoms may change over, during that acute time. There's no abnormality seen on neuroimaging studies. Disclaimer, this is for mild traumatic brain injuries. So these are our concussions. A CT scan is going to be normal. And that's the picture on the left. And the right is an MRI. Those are typically normal. Now, that being said, and I'll talk about a little bit in a second here about severe traumatic brain injuries where the CT scan is abnormal, showing blood, fractures of the skull. So this is mild, this would be considered mild traumatic brain injury where the CT scan doesn't show any findings, any changes, I should say, any acute changes. Another point to think about is that the MRI of the brain, so MRIs are a magnet, they're a little bit more detailed picture of the brain than the CT scan, which as you can see, like the differences. The CT scan on the left is like really grainy, it's not very clear, and the MRI on the right shows you better structure and details of the brain. As technology improves and our MRI techniques and software improves, probably so that we're going to be able to see subtle changes in the brain after concussion on the MRI. So in 5 to 10 years from now, I might have to omit this slide from the talk because we might be able to see these subtle changes on MRI scans. But as of right now, we can't. So the acute phase of the concussion is usually headache, confusion, nausea, vomiting, balance problems, sometimes emotional changes. So even like some aggression or lability, some kind of outward signs of crying, being upset. Of course, that's hard sometimes to tease out because if the concussion happened from an accident of some sort, that's going to be a normal reaction anyway. You're normally going to have emotional changes, say if it was a car accident or a traumatic fall or something were to happen. So, but you can see emotional changes just with the concussion itself. All right. So some things in a brain injury that are more suggestive of a more severe injury. So these are things, these are findings that when they do occur, the patient needs to be evaluated immediately in the emergency room. So one is loss of consciousness for more than 30 seconds, retrograde amnesia, which means that there's memory loss that goes to before the event. So for example, the patient may not remember what they did that day or an hour or so before the head injury. If there's a focal neurologic deficit, worsening symptoms, or seizures. And this is the big, bad, scary thing that we always worry about. In a head injury, and why scans are needed in certain times. And so this is an example of an epidural hematoma. So this is a CT scan, and the big white area is acute blood, is sudden blood. This usually happens with an overlying skull fracture, and then there's bleeding underneath, but not all the time. This is kind of the situation too, where the patient may pass out and then they recover, and then a few hours later, they lose consciousness and die. This is the big scary thing of why, kind of the old wives' tale is after you have a concussion, don't let them sleep, don't let them fall asleep, because, they may not wake up. And this is what's going on in that situation. So what happens is, in this situation, is the head injury occurs, the patient loses consciousness, probably because of shear forces in the brainstem of whatnot, and then they come back. But the bleed has started, and as the bleed moves and accumulates, then the second time they have unconsciousness is going to be from herniation or swelling of the brain. And so this is why we recommend ER evaluations and CT scans for patients that meet the criteria for this, which I'm going to talk to you about this. So the PCARN is the Pediatric Emergency Care Applied Research Network, and it is a bunch of pediatric emergency care physicians that have a lot of guidelines for how to evaluate and manage children with common presentations to the ER. So one guideline that they have that we use a lot in the States is the Pediatric Head Trauma CT Decision Guide. And this can also be attributed to adults as well. So I can go through it. So the first box here is if the Glasgow Coma Scale is less than 15. So Glasgow Coma Scale measures responsiveness, verbal, and your motor skills, movements. 15 is normal. So anything less than 15 would be a CT scan. So yes to any of these would be a CT scan. Signs of basilar skull fracture. So that might be if there's like trauma around the ears or the base of the skull or the frontal bones, or if there's if there's blood in the ear canal. Altered mental status, agitation, somnolence, slow response, repetitive questions. So yes to any of that will be a CT scan, because any of these signs will put you at a higher risk of possibly having an intracranial hemorrhage. So if the answer is to no to these, so normal Glasgow Coma Scale, no signs of a basilar skull fracture, and no altered mental status, it's no. But then if there's vomiting, loss of consciousness, severe headache, or a severe mechanism of injury, which includes a fall greater than 5 feet, motor vehicle accident, struck by a car, struck by a high impact object, then you would do a CT scan as well. If it's no to these, then you would not do a CT scan at all. Now you can always observe. And so what that would be is that the patient would be observed in the hospital if if you elect not to do a CT scan, but maybe they're at moderate risk for any of these criteria, they would be observed. And if there was any worsening of focal or neurologic functioning, then an urgent CT scan would be done. And the idea of that is that if there was blood accumulation, say over the hours after the injury, if the patient was an inpatient to the hospital, then it could be something that could be addressed right away. But that's still a little on the risky part. And most of the time, I would say patients do get CT scans with these criteria. Sometimes as well, in the hospital setting, we might admit the patient and just do an MRI instead of a CT scan. CT scans are radiation, so we want to reduce that radiation risk to children and the developing brain. So sometimes we'll just admit them, watch them overnight, and plan for an MRI in the morning. But that's only if they did not meet any of these main criteria. All right, so second impact syndrome occurs when an athlete returns to play while symptomatic from their first head injury. So of course, this usually happens in athletes because they had a concussion. They may have recovered some, but not completely. They go back to the sport, they get hit again, And when there's a second injury, it's more severe, and they actually have a 50% mortality rate. And the reason why this is kind of plugged more for athletes is because if you were to have a concussion, say with a fall or a motor vehicle accident, just chances are you wouldn't have necessarily a second injury so soon after, if it was just your normal kind of daily living thing. So that's why this is kind of referred to as athletes, because we know athletes, if they have an injury in the sport they play and they go back, they're more likely to have an injury in that sport. Chronic traumatic encephalopathy. This is a little different than concussions as far as we know. It's a long-term consequence of repetitive head injury. So this is something that we see like in boxers or football players, and it's oftentimes in the news called CTE. We feel that this is kind of related or maybe a cause of some of the suicides, early dementia in these patients, Alzheimer's disease. So there's a lot of research looking at this, and this is felt to be not linked to like how many concussions you've had, but kind of a different entity. But, we'll see. That's still being investigated. So sports injuries are the second most common cause of traumatic brain injury in 15 to 24-year-olds. And concussions represent about almost 10% of all high school sports injuries. And almost 4 million sports-related traumatic brain injuries occur every year. So this is something really commonly seen. Risk factors are certain sports and certain positions in those sports. Competitive sports are usually a little bit more, athletes are a little bit more aggressive. And so there's a little bit higher risk if it's a competitive sport of an injury. In terms of girls and boys, so girls soccer has the highest rate of concussion for girls sports, and for boys, it's football. If girls played football, it would probably be football for girls. If boys didn't play football, and it would probably be soccer. So I think the distinguish between those two is really only because football is generally not a female sport. So pediatric concerns, which is a little bit more, a little bit different than adults, is that in pediatric, so a 9-year-old has the head size of an adult. So they have their adult head at age of 9. But as you know, they don't have the height, right, of an adult. And so they still have that smaller body, a weaker neck, smaller neck, and they still have to support that adult head size. And so children are thought to be a little bit more susceptible to head injury just because they don't have the shape of the neck, the musculature to kind of protect the head from a severe movement injury. Same thing with women as well. Women are felt to not have the big, strong necks as much as men have. However, women tend to have smaller heads than men, proportional to the body. So it's hard to say if that really is a mechanical difference, male versus female. But these are just some concerns that we see and some factors that we see. If assessment in the field is very important, if you feel that there has been a head injury, you want to, of course, stabilize the patient and do cognitive testing if possible. There are some evaluation tools that can be done at the field or post-injury or, after the sport is done to kind of evaluate the patient as well. And of course, if there's a bout of concussion, we definitely want the player to sit out and rest and kind of be evaluated later. You don't want to put them back into the game if you aren't sure. So one other thing that I've seen in the hospital with a lot of our more severe injuries or multiple injuries is like for a car accident, a patient may come in and have a broken arm, broken leg, pelvis, whatnot. And the thought of a concussion is not like on the forefront, where they're working on fixing the fractures and the healing time, physical therapy and all that. And then, as they get out of the hospital or get home, then they realize, oh, I'm having headaches. I'm, not doing very well. And so then sometimes the concussion is diagnosed after the fact, just because it wasn't the most severe injury at the time. So a lot of times a concussion can kind of be missed in a way, only because other more important life-threatening injuries are being taken care of. I do see that quite a bit. So what is post-concussive syndrome? So What are some of the findings that patients can have after a head injury? So emotional irritability, depression, anxiety. They can have slow thinking, poor concentration, or even disorganization of thought. Irritability, mood changes, sleep disturbance. Sometimes patients sleep more than usual. Sometimes they sleep less than usual. When a patient is at home and recovering from a concussion, we definitely want to limit loud music, alcohol, and a lot of excessive physical activity, limit texting, screen time, all of that, because we want the brain to rest. The more the brain rests, the quicker the patient will recover. Just like if you had an injury of your arm or leg, you're going to rest it so you don't overdo it and worsen your injury. So then we kind of have to come up with a treatment plan, and all this is kind of broad, and this is when the pediatrician and I had our concussion clinic for these patients. This is the part that we spent most of the time on. Most patients already came in diagnosed with a concussion. They knew they had a concussion, but always the question is, now what? So we want to make sure they're getting adequate rest. Return to school or work is gradual. They might need some accommodations at school once they do return. And of course, return to sports is always after school or work. So any presence of post-concussive symptoms means the patient should not return yet, either to work, to school, to sports. And if the symptoms return, then the patient needs to rest and they did too much. So for example, if a patient's having, say, headaches, and they return to work, say they're having headaches, the headaches improve, they return to work, and then they notice the headaches return or they get worse again, then that means that they went back to their activities, to their work too soon, and that they need more time to rest. A lot of it is a trial and error. Every patient's going to be a little bit different than the others. We do know that if there's a history of headaches, or behavioral mental health concerns prior to the injury, that might prolong the patient's recovery. So acute post-concussive management, for example, at school, so we call that return to learn. And we're going to ask the patient to be absent from school until their symptoms improve, limit time in class, maybe some scheduled rests during the day, and avoid the loud lunchroom. This could also carry over to a work environment where when the patient's returning to work, to have some scheduled rests during the day and avoid loud situations or areas. We also, for the school setting, don't want any time tests. We try to avoid bright lights. A note taker might be needed, smaller rooms, and sometimes patients need to have a tutor because they're having trouble learning and remembering things like they were able to do before the injury. Sometimes also, if the patient's symptoms don't improve, most patients recover in about 2 weeks to maybe a month. But if they're not recovering and still having a lot of struggles, then we'll kind of recruit our psychologists to help and do some evaluations and to help diagnose maybe. So, for example, a lot of times patients may have had some mild attention deficit disorder, and they were able to kind of to accommodate well and to function and to do their schoolwork or their other work well without problems. But after a head injury, sometimes all of that gets worse. Their memory gets worse, attention, concentration. And so sometimes we've even diagnosed patients with ADD following their head injury, not because of the head injury caused it, it's that they had a little bit of it before, never much of a problem, maybe never needed to see, physicians for it, but then after the head injury, now it is a problem. On the other hand, we do have patients with known diagnosis of, say, attention deficit disorder, have the head injury, and things might be worse for a while until they can improve. Similar to mental health, if a patient has a history of depression, anxiety, even if it was diagnosed or not, or treated or not, it will usually get worse after the head injury. And sometimes that might be really debilitating and a big barrier for them to recover from the head injury. So sometimes patients at that point need to start counseling, testing, medications, and what that for that sort. So when can the patient either go back to sports, go back to, do their life? When can that happen? So we want the patient to be asymptomatic at rest. So not having any headaches, emotional issues, sleep disturbances, memory, concentration problems. There is a computer test called the impact test that's about a 20-minute test, and it scores memory, concentration, ability to react. And this can be done as a tool, to kind of follow the patient's progress. Ideally, this test would be done in athletes prior to the season or the games that they're playing, so you have a baseline. But in reality, you're not going to have a baseline. So this might be a situation where you have a patient who may not even be in sports, was in a car accident or had a fall, but we can still use this impact test to kind of follow their progress after the injury. So we want those scores at least to come, to the normal range. We want them to be symptom-free while off pain medications. Sometimes patients will be started on, we don't typically use opiates or narcotics, but things like Motrin, Tylenol, or even some daily preventive headache medications. We want them to be symptom-free and not taking those medications before they go back to activity. And it is estimated about most people or about 40% of patients do return to play too soon. But like I said earlier, a lot of this is you don't really know until you try it. So if you accelerate their activity level and then they start to have recurrence of symptoms, then you know that they need to rest. What is really the danger is patients who have symptoms when they return and keep doing their activity. So we do want what's called a return to play protocol. And the reason why I bring this up is because this is in a lot of the legislation in the states. Each state has a legislation for concussion of when it is safe for that patient, that athlete, to return to activity. And this does kind of apply as well to other things as well. So it's a stepwise fashion. There's a minimum of a 7-day return with activity increasing, and your symptoms have to not increase as well. So here's just an example. So step 1 would be no activity, rest until you're asymptomatic. And then the next step would be to do some light jogging, light aerobic exercise. Then the next would be sport-specific exercise, and then non-contact drills, full contact, and full activity. So pretty much just takes you through 6 steps over 7 days of increasing your activity. At any point, as activity is increased, the symptoms return or worsen, then you need to go back down to the previous step, give that more time, and then try to accelerate yourself later. So dangers of returning too soon to anything. I mean, this could be sports, this could be work, this could be driving. We do find that after a head injury, a lot of patients have a slow reaction time or a slow processing speed. This is something that's hard to necessarily notice, like in the day-to-day living. Like if your spouse or your child has a slow reaction time from a head injury, you may not notice it, just the stuff you do around the house or even the schoolwork. But we know with athletes, they're good athletes because they have a quick reaction time. We also know that all adults driving need a good reaction time to avoid injuries and accidents. So this is kind of the main factor that we see that leads to further injuries. And then, like I said before, with the second impact syndrome, if there is a second head injury while the patient's still recovering from the first one, the effects are usually more severe. So risk factors associated with longer length of recovery is if there's a history of prior concussions, chronic headaches, developmental disabilities, or psychiatric conditions. That's all I have. Any questions?
Can you go over again what you must do if a child get injured, maybe playing or outdoors? Thank you.
Sure. So if a child is injured, you just want to, I guess, the big things, of course, make sure that they're the ABCs, right? Airway, breathing, circulation. But and I think those are that's kind of the more clear-cut situation, right? If a child's hurt and the ambulance is called, that's kind of clear-cut. The question is, and what I get most calls about, or even from friends, what do I do? My child fell down the stairs, they're acting fine, what do I do? And those are always tough calls. So I would say if a child is injured, you want to kind of see, I think mental status is key. So of course they're probably going to be upset with the injury, crying and whatnot, but you want to give them time. And when they, 10, 20 minutes later, how are they acting? Are they confused? Are they throwing up? Are they off balance? Any of those, I would say, definitely take them to the ER. If there's any loss of consciousness, I would also advise to take them to the ER. If there's, up here, I don't know if it's the same down there, but up here, there's again kind of a wives' tale that if they have what they call a pump knot, you all use the same term, like a big knot on the outside of the head, then that means the blood's on the outside and not on the inside, and they don't need to be seen. And that is completely inaccurate, completely inaccurate. So I have heard people say that quite a bit, but I think the key thing would be if they're off balance, vomiting, or any type of confusion, that they should be evaluated in the ER.
Thank
Of
you.
course, yeah, if there's blood also, I didn't mention that, but like even if there's blood and they might need stitches, I think obviously that would be ER as well.
Appreciate it. Thank you.
Okay. Good morning. Can you hear me now?
Yes, we
Yes.
can.
Okay, this is Heather Proctor. Can you please go over again the symptoms of a concussion and delayed
Yes.
diagnosis or for concussion?
Yeah, so actually I'm gonna pull up there we go. The CDC has a great website, and I took these out of the talk for brevity, but I probably should have kept them in. They have, it's called acute concussion evaluation, ACE. And this is all things that you can print online. They're free of charge. Just print them out. And I think it's a really, really useful tool. So here, this one here is a symptom checklist. And so these are the more common symptoms of the concussion. You can see on the left, headache, nausea, sensitivity to light, sensitivity to noise, dizziness, balance problems, blurry vision, double vision, vomiting, numbness, or tingling. And so a lot of times it kind of looks like a migraine, the headache, sensitivity to light and noise, dizziness, like that's kind of those are definitely characteristics of a migraine, but it's going to be with a concussion, it's going to be that sudden change, right? That sudden change related to the injury. So these are the most common physical findings: headache, nausea. But then cognitive, we have feeling foggy, slowed down, difficulty concentrating, difficulty remembering. Now, in a young child, that's going to be hard to assess. Of course, if you know the child, you may have kind of a gut feeling of they're acting right or they're not acting right. But of course, you're not going to be able to ask them, what's your phone number? What's your address? Things like that. So this really, the cognitive part, probably, I'd say probably age 10 and older is something you could rely on. And then the emotional, irritability, sadness, more emotional, more nervous. And we can see some irritability right at the time of the injury. Now, the sadness, that may be more of a symptom that might occur, later on, kind of in your more post-concussive syndrome, not the acuteness. And then over here, the sleep fatigue. So that's also going to be something that you're going to see in the next few days. You're not going to see that right at the onset of the head injury. And I think also with the little kids, since you can't assess the cognitive as well, that's why we do suggest having them be seen at least evaluated in the ER setting. And also be aware, like if there is like a severe injury like car accident or like multiple injuries, a lot of times those other injuries take the forefront, and a lot of this testing or evaluation for the concussion may not even be done because it's, not even, of course, appropriately a concern at that time.
I had two questions. The first was, if someone like on a football field is injured, is the preferred position for resting, is it sitting up or laying down?
As far as I know, it's laying down.
Okay.
And they're also, because historically you're not supposed to remove anything, like no helmets, no pads, like keep it all on. And some new data came out saying that if you know what you're doing, you can remove it. So I just feel like it's safe just not to remove it at all.
Okay, the second question has to do with if someone falls, not necessarily a large distance, but they land on their heels. I've previously taken some martial arts training, and they taught us if you land on your heels, that impact will go up the legs, the hips, the spine to the head. So even though the head hasn't been, you haven't hit your head, the impact, would that be the same?
Oh, it could definitely be. I have not heard that, but I definitely could see that. Anytime the body can have a force transmitted, and everyone's body is going to be a little bit different as well, probably based on their musculature and the activity that they're doing. But definitely I could see something like that happening. And so you could see why it might be hard to diagnose a concussion right after that, because you're like, well, I didn't hit my head, I haven't fallen, you know what I mean? So yeah, it can definitely be a challenge.
Thank you.
Dr. Payne, we do have a comment on the floor. I got a concussion about 4 years ago, and I am still experiencing symptoms. I've been in physical therapy for about the entire time, but progress has been very slow. What are my options to help speed up recovery?
Very good question. I would, it might depend what the symptoms are. If it's more physical, like with a balance issue, there might be, maybe you have like an underlying balance issue or vertigo, something either inner ear or brain that might be contributing to it. So you might want to be looked at ENT wise or neuro wise. If it's symptoms that are like headaches that are still persisting years and years, we do see, especially in families with a history of migraines or chronic headaches, that a concussion can kind of trigger that and kind of make it last lifelong, unfortunately. So if headaches are still occurring, then maybe just going ahead and getting treatment for headaches would be the best thing. If there's continued cognitive or emotional issues years later, then I would definitely suggest getting tested by psychology to see if there's anything kind of underlying. So it's hard to say. It kind of depends what your symptoms are. But definitely, I think if they're still occurring years later, it's definitely worth getting evaluation for looking at like some underlying issues that might be contributing to that. Or even a brain scan if you haven't had one.
Jump in just for a second. I'm glad that Dr. Payne brought up the CDC, because there were some stats that I just found. I think as someone who's a layperson, very much on the outside of the medical field, but very much inside the disability field, I think people would be interested to know some of the stats from CDC that in 2020, there was over 214,000 TBI-related hospitalizations. And out of that, 69,000 of them died. And that was in 2021. So if you break it out, and this is what they have broken out on a daily basis, is that over 586 people are hospitalized every single day due to a TBI, and almost 190 are die from it. And I think that just gives us a perspective of how prevalent it is, how common it is. But at the same time, like Dr. Payne really explained well, you can't see it. You can't even see it sometimes on a microscopic or, technological level with machines. So this is why the symptoms and the manifestations of the symptoms are so important to know about, as Dr. Payne talked about, so that not that you become the diagnoser, but that you become aware of those, of those impacts, and then get treatment to be able then to mitigate the situation. So it's a very slippery slope, I think, when it comes to TBI, because it can be obvious and it can be non-obvious. And so just appreciate Dr. Payne's really great overview of the more non-obvious side at times when it's really hard to pinpoint them. The last thing I want to mention
Shani?
before, yes, go ahead.
I'm sorry. Okay, there was a question. How do you request a brain scan?
I would go to, if it's not acute, go to your primary care provider and tell them, that there's been a head injury and ask for a scan. The best scan to get would be an MRI. Again, if it's not acute. In the urgent setting, CTs are better because they're much quicker. But if it's a scan just to evaluate prior injury, an MRI of the brain is better than a CT scan.
And did you talk about dementia?
Yes. The dementia we see more as a result of what's called chronic traumatic encephalopathy, which is what's like, they feel like it's repeated smaller injuries to the head. So like they always say boxers and football players, but like, so just that repeated head injury, or sorry, impact to the head repeatedly, nothing significant enough that you're like, oh, I had a concussion, but just time after time, year after year of getting head injury or head impacts that can lead to this CTE. And that's been shown to have a risk of dementia. And it's not sure, as far as I know, the literature does not link number of concussions with dementia. But I don't know. We'll see. People are still researching all that.
Mhm. Well, it's such an evolving field, definitely.
Yes,
because
definitely.
Again, and Dr. Payne, any advice, any 30 seconds advice you could give to people to prevent brain injury?
Bubble wrap, helmets. No, I don't do silly things. But life happens. People get injured all the time. You can try to prevent anything you want, and it may still happen.